Dr. Prashant, you can start.
Thank you. Good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room. This program is brought to you by Heathrow Healthcare. Heathrow Healthcare, is an innovative pharmaceutical company with 25 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Heathrow Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world and has Asia's largest manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Heathrow Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, experience sharing program, we have got Honorable Speaker Dr. Manisha Sharma, Senior Obstetrician and Gynecologist, and Honorable Co-Speaker Dr. Gayatri Chowdhury, Anesthetist. Welcome, Dr. Manisha. Welcome, Dr. Gayatri. Dr. Manisha Sharma is Senior Consultant OB Obstetrics and Gynecology attached to ILS Hospital Raipur, Prisha Clinic Raipur, with 15 plus years of experience, faculty in various branches and state conferences, Nari Shakti Sanman Award for exceptional work. Area of special interest include high-risk pregnancy, gynecological disorders, minimum access surgery, critical care OBS, menopause management. Previous attachment, JLHRC, Bhilai, and Narayan Health MMI, Raipur. Welcome, Dr. Manisha. Dr. Gayatri Chowdhury is consultant anesthetist attached to ILS Hospital Raipur with 8 years of experience and areas of interest include anesthesia, critical care and pediatric anesthesia. Previously attached to Narayana Health MMI Hospital Raipur, SGV Hospital Raipur. Welcome, Dr. Gayatri. And over to you, Dr. Manisha and Dr. Gayatri for this. I'll run the slides, madam. Yes, madam.
Or 1 liter, more than 1 liter following cesarean. But usually, according to WHO,
you can see the slides now.
Any hemorrhage causes hemodynamic instability to the patient is known as post-delivery is known as postpartum hemorrhage. So it is very common and it can occur in even women. It is the leading cause of mortality in the developing primary cause of nearly deaths globally. So it is unfortunate yet So it is a leading cause of maternal mortality and it is responsible for 35% of all the maternal deaths. So in developing country, the maternal mortality rate was 240 per 1 lakh live births compared to 16 in developed countries. So global incidence 40 million women suffer from PPH. So in January, incidence is 4% and in cesarean incidence is 6% after the cesarean section. So it is responsible for 38% of maternal deaths due to PPH. And about 26% of global deaths takes place in India. And 2/3 of these are attributed to PPH. So India has an unexpectedly high maternal death rates of 540 per 1 lakh. This was the census in 2021. Now, due to the improved medications and advanced medical monitoring, the maternal mortality rate is reduced to round about 200 per 1 lakh. Coming to the etiology of postpartum hemorrhage, everybody knows there are 4 types: thrombin, trauma, and tissue. So if there is atony of uterus, there is an inability of uterus to contract, which may lead to the continuous bleeding. And there is an increased surface area, which causes more bleeding. And thrombin, there is some coagulopathies defect, there is failure in clotting. And trauma, uterine trauma, any injury to the birth canal, rupture, uterine invasion, lacerations. And tissue, tissue means there is a retention of placenta, clots, or abnormal placentation. So what are the clinical findings in postpartum hemorrhage? There is the patient is in circulatory collapse, there is a status of shock, there is increased and loss of uterine contraction. We can feel that the uterus is very soft and boggy. There is unstable vitals of the patient like maternal tachycardia, and vaginal bleeding continuously, patient becomes pale. So according to the clinical findings, we have divided postpartum hemorrhage into, and according to the degree of shock, it is divided into compensation stage, mild stage, moderate, and severe. And we have to catch the patient and early diagnose at the stage 2 of the shock. That is in early stage 1 or stage 2 of shock, not in moderate or severe status. So this is very important parameters. We all should know that if there is a 15% blood loss, it is compensatory mechanism runs. And if there is 15 to 25% of blood loss, it is mild PPH. If there is 25 to 35% of blood loss, that is 1.5 to 2 liters of blood loss, there's a moderate PPH, and severe PPH when there is a 45 up to 45% blood loss. So in stage 1 and stage 2, the blood pressure, there is a slight fall in stage 2 and the blood pressure does not change in compensation stage 1. And in moderate, there is a marked fall in blood pressure, systolic blood pressure up to 80, and there is a profound fall of systolic blood pressure up to 50, or it is not recordable. Tachycardia is 100 to 120, and in moderate, there is restlessness, patient is clinically pale, and there is decreased urine output because there is no circulation. And in stage 4, there is collapse, patient is angular, patient goes in coma, or patient can be anuric, does not respond. So diagnosing postpartum hemorrhage according to these symptoms, there should be a rapid assessment, and you have to see hypertension. There is a presence of hypertension or there is a tachycardia, and we have to assess the vital signs and how much the amount of blood loss. So examination at the time of hemorrhage, we have to assess the entire genital tract, because as we know, there are four causes: tone tissue trauma and thrombin. So genital tract for lacerations, hematomas, there is a sign of uterine rupture, especially in the cases of VBAC deliveries. And we have to manually examine the retained placenta, and assessment with urgent bedside ultrasound to check if there is a retained placenta, or RPOCs are there and uterus is not contracted or there is free fluid, and evaluation of uterus to check for the inversion. So what are lab parameters? We have to check for CBC, hemoglobin, platelets, coagulopathy to be ruled out, and we have to assess the level of serum fibrinogen. So ideal it is serum fibrinogen level should be more than 100. The approach towards the postpartum hemorrhage for poor uterine atonicity, the clinical findings, we can feel that the uterus is relaxed, boggy, and soft, and sometimes the uterus is above the level of the umbilicus. So investigations sent and how to manage. We should give them uterotonic agents, which causes increased contraction of the uterine smooth muscles. Like there are a lot varieties of uterotonic agents. The most commonly used are oxytocin, carbetocin, come under oxytocin group, and then prostaglandins, and then ergot alkaloids, which are known as methergin, and some other procedures can be done like uterine balloon tamponade. So for management of tears or trauma, you have to thoroughly check all the genital and extragenital causes, and we have to inspect especially during the cesarean section by exteriorizing the uterus, or we can have to see the angles of the scar line, whether there is an extension of hematoma, and if you have to repair the identified trauma. And if there is a supralevator hematoma, uterine artery embolization can also be done. So for retained tissues, the clinical findings can be diagnosed in ultrasound, investigation under anesthesia, and can proceed to manual removal of placenta. For coagulopathies, you have to arrange all the blood and blood products, and they can be a medical management or a surgical management. Surgical management only for the trauma and the atonic hemorrhages, and medical management is immediate replacement of blood and blood factors and platelet factors. Attempts should be made to identify the cause in women who are bleeding in parallel with resuscitation. So Coming to oxytocin analog, rationale for development of carbetocin in a new heat stable formulation. Carbetocin is available in room temperature stable form and in a convenient vial presentation. So oxytocin and other alkaloids should be kept in a refrigerator to avoid the degradation. Heat stable formulation of oxytocin is currently not available because it is a natural analog and it is secreted from postpituitary. So previous formulation of carbidocin were stored between 2 to 8 degree, and in resource poor countries it is very difficult to maintain the cold chain. But in new heat stable formulation, it is stable at room temperature and it is a good shelf life of 24 months at 30 degree and 75% humidity. It avoids the need for cold chain and it is provided in a simple vial. So use of butyronic agents, the timing of administration depends at the crowning of baby's head or at the delivery of HJ shoulder at the end of second stage of labor and following the delivery of placenta. In prophylactic use, prevention of postpartum hemorrhage and active management of third stage labor, and therapeutic use is in management of PTH. So the molecules are oxytocin, carbetocin, ergometrine, synthometrin, which is the combination of ergometrine and 5 units oxytocin and misoprostol. So coming to the uh, oxytocin is a natural analog. So, carbetocin was created to make several modifications to the oxytocin structure, and the focus was on to prolong the half-life of oxytocin. So usually the oxytocin half-life is 2 to 6 minutes, but the half-life of carbetocin is more longer. That is in IV, it is more than 30 to 1 hour, and in sustained IM contractions are there for more than 2 to 4 hours and reducing the enzymatic degradation. So these two mechanisms, modifications were done on in oxytocin analog to create carbetocin. So what is carbetocin? It is a synthetic drug. It is long-acting analog of oxytocin, and the therapeutic indication we have already discussed. And one vial contains 100 micrograms of carbetocin in 1 ml of injection. So what is the mechanism of action? Oxytocin, carbetocin, they are binding molecule. So it binds to the oxytocin and receptor binds the activation of phospholipase E and generate and diacetyl. So these two induces the release of intracellular calcium. And then there is a calcium calmodulin pathway, which stimulates the uterus smooth muscle contractions by activating myosin light chain kinase. So a single IV dose of carbetocin 100 micrograms administered after the delivery of the baby is sufficient to maintain adequate uterine contraction, preventing uterine atony and excessive bleeding with efficacy comparable to hours of oxytocin infusion. So clinical evidences, coming to the carbetocin analog, there were several studies like efficacy and safety of carbetocin versus oxytocin, and WHO campaign trial, which is very famous and was a last study on over more than 35,000 females. Carbetocin is non-inferior to oxytocin. Carbetocin decreases the need for uterotonic agent versus oxytocin, and there were other studies like single dose carbetocin versus continuous infusion of oxytocin, and comparison of carbetocin versus oxytocin with respect to the reduction in blood loss and the need or other interventions, and efficacy and safety of carbetocin versus symptometrin, and efficacy of safety of carbetocin versus misoprostol plus oxytocin. So let us compare oxytocin and carbetocin, which is heat stable. So oxytocin is a synthetic cyclic peptide naturally occurring from postpituitary. It binds to the oxytocin receptor as we have discussed previously. And pharmacokinetic is given usually intravenously. Almost immediate action occurs with peak concentration after 30 minutes. And I am slower onset of action. It takes within 3 to 7 minutes, but it produces a long-lasting clinical effect up to 1 hour. And half-life is already discussed, is 1 to 6 minutes for oxytocin. and it requires a protection from light and storage at 2 to 8 degree to preserve its activity. Coming to heat stable carbetocin, it is long synthetic analog of oxytocin with agonist properly binding to the oxytocin receptors and stimulates the uterine muscles contractions and causes rhythmic contractions, increases the frequency of existing contractions, and increases the uterine tone. And IV, it can be given IV or IM. IV, sustained uterine contractions within 2 minutes, lasting for about 6 minutes, and followed by rhythmic contractions for almost an hour, 60 minutes. And IM dose, sustained uterine contraction lasting for about 11 minutes, and rhythmic contractions for about 120 minutes. The half-life is 40 minutes. Storage condition, it is heat stable, so it can be stored up to 30 degrees Celsius. So this was WHO champion trial. Carbetocin was non-inferior to oxytocin. So blood loss of more than 500 ml or the use of additional uterotonics, almost there was a similar efficacy. And then blood loss of more than 1 liter, it was almost the non-inferiority was established. So at least one anticipated amniotic fluid embolism, the safety profile in both the oxytocin and carbetocin was almost similar. So the frequencies of expected embolisms did not differ significantly between these two groups. The frequency of blood loss of at least 500 ml or the use of additional uretonic agents with carbetocin was proven to be non-inferior versus oxytocin. So the conclusion was it is non-inferior to oxytocin for prevention of blood loss of at least 500 ml or the use of additional uretonic agents. Coming to the Cochrane review, carbetocin for prevention of postpartum hemorrhage. In this Cochrane review, data from 11 studies involving 2,635 women were included, and the author concluded that for women who undergo a cesarean, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. And carbetocin is associated with less blood loss compared to symptometry in the prevention of BPH for women who have vaginal deliveries and is associated with significantly few adverse effects. So what are the guidelines and recommendations coming to this section? So all the societies all over the world, Society of Obs and Gynecologic Society of Canada, Danish Society of Obs and Gyne, and Ministry of Health of Russian Federation, Chinese Society of Obs and Gynecology, Philippines Obs Gyne Society, Mexican National Center for Health Technology Excellence, and Queensland Maternity and Neonatal Clinical. These all societies, they gave the guidelines for PPH management. Like only one of the following, oxytocin, carbetocin, can be used for prevention of PPH and PPH management. And 100 microgram is given slowly IV. And WHO and France Obs Gyne Society also, they told that carbetocin on proving non-inferiority to oxytocin. Coming to my experience with oxytocin, it is the smartest, superior, and a choice in PPH management. Let's discuss some case studies. So, case 1, effective use of carbetocin preventing PPH in a normal vaginal delivery. So, 31-year-old primary gravida with hypothyroidism underwent induction of labor for post-pregnancy. She received misoprostol and oxytocin for liver augmentation. After delivering a 2.5 kg baby boy, she was administered a 1 ml slow IV carbetocin over 1 minute, prevents postpartum hemorrhage. The outcome was average blood loss was PPH of
I think the internet connection is.
case 2 in a cesarean section. My experience, there was a lady, 34-year-old second gravida with a previous seizure and gestational diabetes mellitus. She presented with placenta accreta spectrum at 37 weeks.
Madam, in between you are not audible because of the internet connection, I suppose.
Oh, I'm so sorry for this.
No problem, no problem.
Okay, sir, am I audible now?
No, yes.
So coming to case 2 in cesarean section, carbetocin in placenta accreta spectrum. So this patient had a placenta accreta spectrum, but it was a grade 1 placenta accreta spectrum. Only a few layers in the middle of the placenta there was an absence of metabolic membrane, and MRI pelvis was done. She underwent the elective seizure with all the second hand, everything was ready for cesarean hysterectomy. And she received carbetocin 1 ml IV along with tranexamic acid post-delivery. There was blood loss, only 200 ml, and her vitals remained stable. And there was no need for any blood transfusion. So key points, high-risk cases with placenta accreta and prophylactic use of carbetocin and tranexamic acid. There was minimal blood loss, vitals were stable, and it effectively managed the uterine tone, contributing to decreased blood loss in this high-risk patient. And in this case, the carbetocin also played a crucial role in managing postpartum hemorrhage risk associated with placenta accreta syndrome. So coming to case 3, it was a high-risk pregnancy. So carbetocin in a triplet pregnancy. She was a 39 female, primary gravid. She was an IVF conception, and she presented in emergency with leaking PV, and she delivered triplets 1.3, 1.5, and 1.7 kg via emergency LSCS. Carbetocin and tranexamic acid were administered during delivery. Outcome, average blood loss was less than 200 ml. There was no atonic PPH, and the vitals were stable. And carbetocin worked wonderfully. They were effective uterine contraction and prevented the excessive bleeding. And there was a synergistic effect of tranexamic acid. It augmented the carbetocin's effect. So prophylactic use of carbetocin, it mitigated the atonic PPH risk in triplet pregnancy. Now we are ready to take some panel questions.
Yes, madam.
Prashant sir.
It was wonderful, madam. I mean, the triplets case is the first time that I've heard, Carbetocin.
Yes.
Very nice to hear.
So that was
One thing
also
I
first
want,
case.
they were all identical, must be, because of IVF, I'm
Sir,
asking.
no. Sir, those actually 2 ovas were transferred, and
Okay.
both of them got well placed, and then one
Hmm.
of the twin it became a monochorionic twin,
Oh,
monochorionic, monoamniotic, one set of twin. So out of that, the first of the twin had some congenital
yes,
hydrocephalus
yes,
or
yes. We
some
highlighted
sacral
that.
agenesis. But the thing was, the mother, she was herself a pediatrician, and she
Oh,
told that, no, I don't want to take any risk and I don't want to go for a reduction. And
absolutely.
she managed with, she was well managed with all that.
How long you have been using Carbetocin, madam?
Cover.
Yeah, how long you have been using Carbetocin?
So I've been using my carbidose past 2 to 3 years, and
Oh,
I've used in more than 500 patients
okay.
in all the normal deliveries and cesarean. I've stopped using oxytocin. Oxytocin is used
Okay.
only for induction and augmentation of labor.
Yes. And you
And
generally use IV form?
sir, I use IV form. And if I think there is a chance of secondary PPH or atonic PPH in future, then I can give one IM dose.
In which patients you can anticipate PPH, madam? Of course, one is to triplets, twins. I mean, that's a certainty because uterus can become atonic.
So there is no common consensus that which patient are high risk for PPH, any of the patients,
These triplets
but
have
there is a risk category.
these triplets have influenced me
Sir,
more because I have got twin granddaughters.
oh, okay, sir.
Fortunately, my daughter-in-law did not get any PPH.
Okay, sir. So usually in high risk pregnancy cases, those who are in prolonged labor or those who have prolonged oxytocin augmentation of labor, and those are in chorioamnitis, those patients or triplet pregnancy, twin pregnancy, or there are more than 3 or 4 previous LSES or 3 or more normal
Oh,
vaginal
oh,
deliveries.
correct.
Those are the high risk cases for
And of course, anemia remains a high risk in our country always, all the
yes,
time.
sir.
Any experience, madam, of use of carbetocin in retained placenta?
Sir, in carbon, I have usually we should do manual removal of
Yeah, yeah,
placenta,
correct,
and
correct.
after the manual removal of placenta, we need a sustained uterotonic. So post
Yes,
delivery, we should give carbidose.
correct. I mean, because that advantage of sustained contraction helps in
Yes, sir.
case of after the placenta is expelled, of course.
Because the half life is more for
Correct,
carbidose and
correct,
amnion.
correct,
So we have to give a sustained uterine contraction for at least 1 hour or 2 hours.
you would absolutely
So in that case, carbidose is helpful.
help. And in RH negative mothers,
Sir, in RH negative mother, usually like how we give oxytocin, we give carbetocin.
similarly.
There is no risk factor for RH negative mother. Only what is mentioned is the cautious use in cardiac disease patient or
Yes, yes.
asthma patient, but no mention for RH negative patients. Sir.
I mean, many doctors, and everyone, almost everyone uses oxytocin for labor induction. Can they use carbetocin afterwards for prevention of PPH?
So I have not seen any clinical studies or there were no
Yeah.
guidelines about the carbetocin.
But you have been using it, because I've seen in your cases you have been used. But in both these cases, I've seen you use carbetocin and tranexamic acid together.
Yes, sir. In only those people, those who have a low platelets
Okay,
or there is a PTINR is raised,
okay,
prothrombin time is raised. In those cases, we give tranexamic acid if there is a mild high risk of bleeding.
correct.
Uh, we are suspicious, so we give 1 gram prophylactically, 1 gram tranexamic acid.
So we cover both the aspects, uterine contraction as well as bleeding parameters.
So uterine contractions can
Yes,
be
with
corrected by
carbetocin.
carbetocin.
Correct, correct.
In tranexamic acid, it cut down the blood loss to
Blood
almost
loss. Yes.
50%. So in that way, the maternal morbidity and mortality
Yeah,
will
yeah, yeah. You have
improve.
been using IV, but you have said that IM route you prefer when you are more worried about the secondary PPH. Otherwise, generally you prefer
Yes, sir.
IV route.
Yes.
Any adverse effect you have seen with carbetocin?
Till now, I have not seen any adverse effects of
Major adverse.
carbidol.
If suppose the patient doesn't respond with carbetocin, which other additional uterotonics you would use in your order of preference?
Uh, so I think in till now, in my cases, I have not experienced any bad
Very
happening
nice. Very nice.
because we are having vigilant room. And
Huh.
if suppose the carbidol is not working, then we have to do the other measures like uterine massaging. We have to rule out any retained placenta, any other coagulopathies, and then you have to call for help. And our anesthetist madam is there.
Yeah,
She
yeah,
runs
yeah.
comes for help.
Finally, it's her call.
Yes, sir. You're totally dependent on a good anesthetist.
Absolutely. Usually, I got one question subsequent to receive. What are the advantages of carbetocin over other uterotonics? I suppose in our country, storage is one thing, not requiring refrigeration. It's a major thing in our country. But besides that,
So it is a heat stable.
it's stable. Correct.
Carbetocin is a heat stable thing. It can be stored up to 30 degrees.
Correct.
Mars is a tropical country. And during summer, it is difficult, na, potency of oxytocin because we have to
It
store
becomes
it 2 to
less.
8
Yes.
degree. If there are different power failures, and especially in all the remote areas where the
Yeah, yeah, yeah.
refrigerations and other cold chain is not maintained, the efficacy is lost for
Correct.
oxytocin.
Should carbetocin be kept as a
And
reserve drug?
moreover, the half-life of oxytocin is,
Yes, very long.
so
Should be kept as a
yes, sir.
reserve drug as
So
a first
half-life
line?
of carbetocin is long.
No,
Now I'm using it as a first line drug for
first line.
carbetocin. And suppose it is not available, then go for oxytocin.
Now, madam will have to answer this. Role of anesthetist vis-a-vis gynecologist in deciding drugs for PPH control or prevention.
Uh, uh, Sir, most of the times this is a team approach, team-oriented
Correct,
approach.
correct, correct.
Yeah, anesthetist and gynecologist and all the OT staff, we always communicate. Continuous communication is there
Yes,
about
yes.
regarding the bleeding and patient hemodynamics. And as most of for last 3 years, I am working with Manisha ma'am, and we are using carbetocin in each and every patient.
Absolutely.
So, uh, so the I have hardly seen any PPH in ma'am's case
Very nice.
actually.
You should not
But
see also.
previously,
Yes.
so previously when we were doing it, it is a team approach. So
Absolutely.
continuous communication with the obstetrician regarding blood loss and we being vigilant in OT for patient hemodynamics and continuous measurement of and estimation of the blood loss.
Correct.
We can go for any like hemodynamic management, like
Absolutely.
IV fluid resuscitation, need for any blood transfusion. And
And we are totally dependent on anesthetist for that hemodynamic management because it is anesthetist domain. You people will control it well, and then we are relieved.
Yes, sir.
Thank you. Yes. And one thing wonderful, PPH is a topic which is excellent to discuss and debate, but one should never see a case of PPH.
The postpartum hemorrhage is a
That's what I
nightmare for any
And
obstetrician or as well as anesthetists in the team.
my first question was that where you expect. In fact, I will say that you get PPH where you don't expect it. That's it. That's what happens sometimes. And finally, take home message for the audience.
Sir, I will say that carbetocin in a heat stable form, and it is almost the structure similar thing, and is very good to use in a tropical country like India and other countries. And it has more T half-life,
Yes,
what
correct.
we understood from all the presentation, and there is sustained rhythmic contractions. So we should go for carbetocin for prevention of postpartum hemorrhage. And my experiences with carbetocin is wonderful, and there is hardly any loss of blood. Sometimes I've seen blood-less surgery also
Oh,
postpartum,
yes.
less than 100 ml of blood loss.
Correct. And it's
So
wonderful.
we manage atonic PPH very well.
Correct. And it's wonderful to see a team working, because then it becomes a very well coordinated effort.
Yes.
Thank you so much. Thanks, Dr. Manisha. Thanks, Dr.
Thank you
Gayatri.
so much.
Thank you so much, sir.
Thank you.
Thank you,
Thank you.
Thank you everyone to give your time for us.
We
There is a
can
valuable discussion.
log out. Thanks, Dr. Gayatri. Thanks, Dr. Manisha. It was a lovely,
Thank you,
and I'm
thank you,
sure
sir.
those triplet cases and those cases, those especially high-risk patients, has given confidence to the doctors who have attended. And the teamwork of anesthetists and gynecologists always is the best.
Yes,
Thank you.
true.
Wish you a very
Thank you,
pleasant
sir.
evening. You can log off, madam. Thank you.
Thank
Yeah.
you, sir. Thank you.
Thank you. Thank you so much, sir.
Thank you so much. Thank you. Thank you. Thanks, Sanjana. Thanks, Bivas. We can log off, madam.
Thank you, ma'am. Thank you so very much for this wonderful session. Thank you, Gayatri, ma'am,
Thank you.
for your